Welcome to At Home Rehab's Skilled Nursing Visit Note Training. Before watching this video, you should have already reviewed the printed basic guidance and the sample visit note with examples. Jen's going to review how the clinician who opens the case enters information that will carry over to all future notes. Then she will go over how the notes should be completed at each of your visits. I'm now going to turn over to Jennifer, who's going to take you right into the visit note.
If you have not read the guidance that was sent to you, the general guidance about the notes, please pause the video right now and go and review that, as it will be very helpful, as I'm not going to be reading every detail of it. I'm just going to be going through it in a general way. So first of all, one of the biggest changes with the new notes is that the OASIS is now going to be a separate document from the notes. In the past, the OASIS, the actual clinician put their skilled services on the OASIS, and it was one note. We're now going to separate that out. So the OASIS is going to be an administrative document that will not be billable, and the actual visit note will be the billable note. So the clinical data will be taken off of the OASIS. So it will be shorter so that the clinical data can be on their note. This will allow the PTAs and LPNs to be able to see that clinical data much more quickly, because it is a regulation that notes are finished by midnight of the same day. So the PTAs and LPNs will be able to see their goals, their orders, and everything immediately and not have to wait until the OASIS is complete for that. So we feel this should be helpful for continuity of care and efficiency. The first section is history of present illness. And I've just displayed a few examples on the note of some things, but in your guidance and also on the note that I sent you in paper, there are a few more examples. So the first example there I've written in, and basically what you're going to do here is tell the story of what happened. What changed with this patient? What's different than what they were prior? And why do they need our services? Because of what changed? And you want to include their diagnoses also in this. So basically the story should say, this is how they were before, this is what changed, these are the diagnoses, and this is what we're going to do to help them either get back to their prior status or reach their maximum function, depending on the diagnoses, of course. My suggestion is, under history of present illness, to list the diagnoses first so that they're very clear at the top, and then go into your story so that the diagnoses will show up on every note moving forward. The next section is frequency and duration with start date. This will populate to the plan of care. What you write in this box, what the RN, and I didn't mention also, the history of present illness will be filled out by the RN, the PT, the OT, whoever is the first person out on the case, and it will carry through from note to note, so everybody will be able to see it on their notes. This frequency and duration also will be filled out by your RN, your PT that is starting the treatment, so that everybody can see it with the start date. Make sure your ranges aren't too wide and be as specific as possible. Be realistic. What do you think this patient needs? And it's based on your judgment at the time that you see them. Of course, that would change, and then that would warrant a change in the orders. And the start date is there for your reference, so you know when those orders started. If they need to be changed, of course, they would need a new physician order. So you're going to write a new physician order, and then you're also going to change it here because it's going to carry forward from note to note. The next section also carries through to the plan of care, so that, like I said, when that clinician on the first visit writes their skilled note, this is going to carry right into the plan of care. So anything after the physician orders or wound care orders, you need to do a separate order, anything that you're adding after that plan of care is established. So you would do that on a physician order form or a wound care order form. So you're going to write exactly what you're doing with the patient as specific as possible. So if it's a new diabetic and you're doing new diabetic teaching, when to report their blood sugar readings, any type of thing like that. You don't want to just write a general, diabetic teaching. You want to write as specific as possible what you're doing with that patient. And there are further examples, obviously, on the written documentation that I sent in the guidance. Homebound reason is the next topic. And although we're checking these off, the blanket statements such as needs assistance for all activities, they're very general statements that could apply to just about any patient. So we really want to make sure we're writing in that section that says other. And we want to put something specific that would only apply to that patient and not a group of patients. So a big thing with nursing that we could find is psychological disorders that cause them to be homebound. Maybe they're living in a boarding home. They have Alzheimer's. They have cognitive issues that require them to have assistance at all times. Shortness of breath that limits their ability to move around for a certain distance or dependent on oxygen. So these are just some examples, but you want to be specific. Again, like this particular patient has advanced Alzheimer's, they cannot go out alone, they need a person with them at all times. And make sure as their homebound reason changes that you're changing them from note to note, because this information does carry through from note to note. So you want to make sure you're always keeping it up to date. Under the vital signs, that's pretty straightforward. Cover yourself as much as possible. If you need to reporting a sitting and standing for orthostatic, make sure you're doing that. Do not report blood sugar or oxygen levels unless the patient has their own machine and they report it to you. And please note that on your note. We are not in a position as an agency right now to do this. If you have further questions about it, please ask me. Under subjective, you want to make sure that it's specific as possible. Again, I'm going to repeat myself. Not a statement that can apply to every patient. So it shouldn't just say, I feel great today on every single note. It should relate to your goals, your care plans, and your patient's limitations. So if the patient, for example, had fallen and hit their head, you might want to write, something to the effect of maybe when their head hurts or when they have headaches or the headaches are easing down, something like that to show how they're doing with their care and your specific care plan. Medication changes, you want to list any changes. So on every visit, you want to probe and ask that patient any changes that occurred, especially if they just had a doctor's appointment or they just came out of a hospital and there's been a medical intervention. Even more probing is necessary. Include vitamins, minerals, eye drops, lotions, everything that patient is putting into their body, onto their body. Very important. For example, if an ambulance came for that patient and their medication list was not up to date, and they took that list and the ambulance driver gave them something that interacted with a medication that was not on that list, we could be liable for that because we are the agency that's keeping their medication list up to date, and it is part of our regulations to do that. So keep that in mind. Under the assessment section, please make sure that on each visit you're highlighting something that shows improvements relating to your goals, your care plan. And make it specific and objective. Not just, patient is able to use their glucometer better. You want to say that last time the patient needed 100% verbal cues to use their glucometer, and this time they only needed 50% verbal cues. So you want to definitely make sure it's very specific. Even if it's short, it doesn't have to be long. It could be a few sentences, but as long as you highlight something different. If the patient didn't get better, and they actually got worse or they stayed the same, that's when you want to highlight why. What is limiting them from getting better? Why did they stay the same? So if they're not improving, don't feel pressure to. So the next section is your plan. You want to state exactly what you're planning on doing. Stay away from writing continue or continue per plan of care or continue per doctor's orders. We want to stay away from those general statements. We want to write the date that we will be returning. If you don't know the exact date, you can write, we'll return in 2 or 3 days. 2, and what are you going to do? Teach the patient how to use their glucometer. Or review signs and symptoms of hypoglycemia. Or perform wound dressing change. Whatever you're going to do on that next visit, it doesn't have to be everything you're going to do on that next visit. It should be the primary thing that you're going to do on that visit that takes the most amount of time during the visit. So on the supervisory visit section, that is only going to be filled out by the RN when they're supervising an LPN or when they're supervising a home health aide. The LPN can leave that section blank. So the next section is fairly new to the note. It's the chart. And I'm just going to go to pass through one row of the chart just so you get an idea of how it flows. So on the first visit, the RN is going to complete the prior status, which is defined as the patient's status prior to this change in their medical status for the reason we are treating them. So if they had a stroke, they're going to list what their status was prior to the stroke, prior to the date and time they had this stroke. What was their pain? Status on eval column is going to state exactly what their status was on the day of evaluation. Now, day of evaluation is defined as 24 hours from the time you are there, encompassing that 24 hours. That is how it is defined on the OASIS, and that is how we're going to define it on our care plan. So if you're there at 8 o'clock in the morning and the patient states that they had 10 out of 10 pain at 8 o'clock last night, 12 hours prior, you're going to document that worst pain status within the last 24 hours that you were there. Their current status actually will not be filled out on eval. That will start the visit after evaluation, so the evaluating therapist or nurse can leave that blank. Short-term goals and long-term goals are now required by the state. They are no longer going to accept care plans if they don't include a short-term and a long-term goal. So the best way I would suggest doing this, and also I want to mention that these goals will populate to the plan of care on your first visit. The thing I want to mention about this, and the easiest way for me to think about it is, think about your long-term goal. How do you want this patient to be when you're finished with them? And think about how long you think that might take and put that date in there. And then just split it in half. Or some people like to do their short-term goals as 2 weeks from their eval. However you like to do it is fine, as long as you just identify how you're doing it. So you put your proper date, and you say, oh, I think that they're a 10 out of 10 pain now. I think I can get them to an 8 out of 10 in 2 weeks. So that's what you'll put for your short-term goal. But remember, in the prior status, status on eval, and current status columns, you can write just 10 out of 10 or just what the result is. In the goal, you actually have to write the complete sentence out. Pain levels decreased to 5 out of 10. If you just write 5 out of 10, the plan of care is just going to say 5 out of 10, and no one's going to know what you're talking about. The doctor gets that plan of care, and it needs to be a full sentence, the goal. Well, it doesn't actually have to be a sentence. It could be pain, 5 out of 10, write an A. So writing it as efficiently as possible is always good, because then you'll be able to see the whole thing and grasp it and not have to read an entire sentence. I tend to like writing things more efficiently. So if the goal is met prior to, now you can change these goals on any visit and they'll move to the next visit. At least that's the goal here. If it is changed, you can actually write the word goal met. And if you could do that in caps prior to the goal. So then when you're looking at it, it will carry forward to the next note. You'll know that that goal was met. If you would like to change that goal and you think they can reach a further goal, then instead of writing goal met, just change it to a new goal, and in your narrative section, just document that you've changed the goal and you feel that this patient is progressing nicely and then they can reach a further goal, and just note that why you've changed it. Also, the LPN in this instance, in any of these columns, if you have additional information that you would like to add, you can. Now, as far as the prior status and the status on eval, that will not be editable. That is only going to be staying from that eval. But you can add things in your narrative to explain anything further that you have found with that patient. So the last section of the note is the narrative, and this narrative allows you to put anything you want that was not in any of the previous boxes. So any treatment performed that you did, and make sure you make it the exact interventions you did, not just wound care per MD orders. It has to be exactly what you did. Remove the dressing, step-by-step instructions on what you did. And example, even with communication, people that you communicated with during the visit, any new education that you provided specifically, any new instruction. So make sure you really detail what you did in the visit and cover any bases that you didn't, even explanations of things that you may have put in the chart or previous sections that you want to explain further that you didn't want to junk up those sections with. I would be as brief as possible in the chart, and any further explanation should go in this narrative section. So that completes the note. I just want to add that I'm really trying my best to both meet the regulations as well as make things as easy as possible for the clinicians. These are not set in stone. Please provide feedback immediately or as you do the notes all along, and Vero can make modifications. And the other thing I want to mention is that the mapping from note to note, everything will map over from note to note. So you need to not be lazy. The reason I did this for you is so you can see how they were on the last visit. So please make the changes. If you feel that something should not be mapped over, please let me know. The fields can be changed to not be mapped over. The bottom line is that if I do see a trend of people being lazy, I'm going to have to remove the mapping from certain topics that I see that trend in, and I can only remove it from all staff or no staff. So it has to be all or nothing when it comes to each individual field being mapped. Thank you for your attention, and I hope this has been helpful for everyone.